안녕하십니까. 배정인 원장입니다.
Greetings, I'm Dr. Bae Jong-in. Today I'll discuss the design and material selection for anterior aesthetic implants. First, let's talk about design. Looking at how treatment is approached in the aesthetic zone of the anterior region, for this patient, tooth number 11 was extracted and immediate implant placement was performed, followed by provisional delivery. During healing period, gingival profile was modified, and when it was satisfactory for both patient and me, and when ISQ value was improved, final abutment and final crown was fabricated. The process of prosthesis design, yes, it starts after implant placement. We start off with provisionals. This is initial design. It is modified based on biologic feedback and patient communication. The design that is changed is referred to as transitional design. After that, we move on to final design. That is the overall order. After implant placement, the area that we can design is the top part, the area that goes through the gingiva, and here. It can be divided like this. We talk about emergence profile. This refers to the contour of prosthesis around the gingiva. Depending on the situation, the transmucosal element called a running room is also referred to as the emergence profile along with surrounding gingiva. As a whole, you can refer to this as emergence profile. White aesthetics are influenced by the crown, but the emergence profile and a ridge wrap design also affect the pink aesthetics. Our design should start with the emergence profile. Let's look at a literature in this regard. In 2019, a paper under the title Restorative Emergence Profile for Single-Tooth Implants in Healthy Periodontal Patients, Clinical Guidelines and Decision-Making Strategies was published. The title sounds quite daunting, but in this literature, it divides the emergence profile into two categories. First is critical contour. It is visible to our eyes. From free gingival margin, 1 to 2 millimeters of area is referred to as critical contour, and below that up to implant top is referred to as subcritical contour. How the design is determined here is the key. This is something that we may all know. It needs to be similar to the natural teeth. In the critical contour, it needs to be convex. And below, it is either straight or concave. Depending on implant position, it may vary. Ideally, if implant has been placed palatally. In the case of critical contour, if the implant has been placed ideally, it should be convex. But if the implant has been placed labially, if it becomes too convex, it will put pressure on the gingiva, which will then lead to recession. It should be either flat or concave. If implant has been placed too labially, it becomes concave and there can be ridge wrap. As for subcritical contour, the basic is flat or straight. If the implant has been placed sufficiently palatally, in order to provide more gingival support, you can at times provide a convex design. If the implant has been placed palatally, you can have more leg room, but if it is placed labially, because we need to prevent the pressure on the tissue, it needs to have concave design. In the case of interproximal area, it can be concave or straight. If the surgeon wants to control the papilla, The surgeon can also add convexity. This literature is a bit more detailed. It's from 2021. The previous study divided emergence profile into 2 spheres, but here it is divided into 3 spheres. This is EBC concept, aesthetic, biologic, and crystal. The design guideline is that in the C area, it is about 1 to 1.5 millimeters. It should be straight, and in the case of B, which is around the CEJ, it is about 1 to 1.5 to 2 millimeters. So it should be more convex. And the B area, depending on implant positioning, if it has been placed buccally, it can inevitably become concave, but if the implant has been placed palatally, you can add convexity to it. So this is a more specific guide. With this concept in mind, I want to show you how it's actually applied. In order to design implant abutment, we need to come up with a pre-design. You need to adjust the contour so that it is harmonious with adjacent teeth, and you need to mimic root shape and design the gingival side like this. Following that, abutment design is done. You need to remember EBC. I'm going to focus on E first. We can consider the pre-design. The transitional area between abutment and crown can become slightly convex or sharp. It needs to be below 1 to 2 millimeters subgingival. And here, it needs to be positioned about 1 to 2 millimeters from here. In the interproximal area, because there is a little possibility of emergence profile becoming too sharp, this in general follows the pre-design. Once the CEJ is determined, we need to focus on B and C out of the EBC concept. Crystal side needs to be straight, and in the middle it should be straight, or depending on implant position, you can provide a bit of volume like this. In a sense, it looks quite simple. You do pre-design. CEJ is set 1.5 and 1.5. Here it's straight, and here it's concave or slightly convex. As for the interproximal area, it should be straight or slightly concave. It sounds simple, but actually, implant placement position should be ideal, and pre-design should have been done nicely. When we design EBC, I've talked about setting this 1.5 millimeters here. Just as natural teeth have a slight convexity at the CEJ area, implanted prosthesis should have the same. Providing a bit of volume can lead to a more appropriate support for the gingiva and more natural emergence profile. If you look at the intraoral image in the CEJ area, it's more contoured. You may think it looks a little bit artificial, but if you look at the intraoral image, you can see that there is a very natural looking emergence profile. This is EBC concept. Straight, convex. You can design it accordingly with different situations. It can be applied to various abutments, and depending on abutment type, EBC can all be reflected in the abutment, and in this case, B and C will be reflected in the crown. We need to apply EBC concept on different abutments. If the figures of EBC are as shown, if you add them up, it's about 4 to 6 millimeters. We need to place the implant 3 to 4 millimeters deeper than the free-gingival margin. In order to proceed with prosthodontic phase more smoothly, you need to place it 5 to 6 millimeter deeper. That is my preference. If you look at the image, the implant has been placed 5 to 6 millimeters deep. The link abutment takes up about 1 millimeter.
링크 어버트먼트가 대략 1mm 정도를 차지하고 있네요.
If you check the fit intraorally, it looks like this, and on top the crown goes up and you can complete aesthetic prosthesis. It may look aesthetic, but there are certain risks. The cuff of link abutment is about 1 millimeter, so from the implant top, it widens drastically if you compare the two. Comparing 1 millimeter and 2 millimeter cuff, in order to give a more straight feel in the CJ area, you need to choose the right option. If you look at the X-ray image, looking at link abutment, 2 millimeters are recommended. If you are to use stock abutment, if you use short abutment, it's the same with link abutment. If you choose a short abutment, you get more room to design. In the C area, we may infringe upon the principle where we need to avoid pressure on the adjacent tissue. The stock abutment needs to have about 3 millimeters of cuff height in order to provide a more biologically favorable result. Link abutment, 2 millimeters of cuff height is recommended, and for a stock abutment, 3 millimeters is recommended. The abutment contour following the EBC concept, as mentioned,
이렇게 EBC 컨셉으로 디자인을 한 이 어버트먼트 외형은 사실은 우리가 아까
if you look at the different phases, initial, transitional, and final, this is initial design.
이니셜에 해당하겠죠. 그 이니셜 디자인을 입 안에서
When appropriate pressure is applied, there's an apical migration of gingiva, and we can adjust the position and we can adjust the papilla as well. We can get the biological and communicational feedback and then get the final prosthesis design. As we all know, adding resin to the temporary is not a difficult thing. Once transitional prosthesis design has been complete, we need to get the same emergence profile with the final prosthesis as well. In the past, we would copy the lower part and make a custom impression coping. Using digital dentistry, you can scan transitional prosthesis and then align to coordinates of the final scan. Then you'll be able to reflect the design of a transitional prosthesis to final prosthesis very easily.
보철 또는 파이널 어버트먼트의 이행 보철을 아주 편리하게 반영을 할 수가 있겠습니다.
Last but not least, in order to remove cement, as for ER type, the screw hole needs to be towards the lingual side in the anterior zone. At times, you can use angle driver if there's limitations in placement position. The diameter of the shank of angle driver is narrower, so it can move more easily within the abutment. By utilizing this, you can transition into ER type. At times, you may need to adjust abutment. It is easier to adjust and remove stock abutment. In the case of zirconia abutment, there's link abutment within, and there may be need to remove a bit of link abutment as well. However, if you do it, there can be disadvantages in terms of bonding, so we need to pay a lot of attention. After adjusting abutment, following the changed position, hole is formed on the crown. You put the angle driver in the abutment, and when you scan this, it can be of help in determining hole position. I've talked about design thus far. I want to talk about material selection right now. There's a slide that I wanted to show you. This is my mentor's case. Can you discern where the implant crown is? Surprisingly, it is number 21. It is not all ceramic crown. It was PFZ crown. It was external type Brownie mark implant. A lot of people prefer internal type all ceramic crown these days in terms of aesthetics more than material itself. The surgeon's understanding of the case, positioning the implant accurately, and designing the prosthesis appropriately is more important than material selection. Please bear this in mind. This is a photo from the central lab of Seoul National University. There's Emax stained monolithic zirconia and veneered PFC. Can you tell the difference? An experienced dental technician can achieve satisfactory results regardless of the material, so it's essential to understand the case, perform ideal implant placement, and utilize design techniques. These are more important than the material itself.
테크닉에 대한 이해, 그것이 재료 자체보다 더 중요함을 명심해야 되겠습니다.
The necessary properties of these materials include mechanical aspects like fracture strength or flexural strength. Also, we need to understand optical properties to adequately provide white aesthetics. If we talk about translucency, it's in between opaque and transparent. We all know about hue value and chroma. This is created from our sheet guide. There's also opalescence and blueness. When our natural teeth are under external light, or say we have a bulb in our mouth, they will appear differently. The effect when lit from inside the mouth shows darker areas, and this is the opalescence effect. We talk about teeth having opaque halo. There's opalescence halo and the mamelons. When we produce a dental prosthesis, catching these details and sending them to the lab can be very helpful. Materials for implant restorations include those for abutments and superstructure. Though metal is commonly used for abutments, we also use zirconia abutments. Zirconia abutments used for aesthetic zones has a link abutment, and in the middle there is a mesostructure. Moving on to core of the crown. For the core, metal or precious metal can be used, and zirconia can be used as well. As for zirconia, monolithic zirconia can be used, and as for glass ceramic like Emax, it can be used for core, monolithic, and veneering for zirconia, albeit less frequently. When aesthetics is important, the porcelain powder can be used for layering, and the use of polymer and hybrid is gradually increasing. When making crown, there is monolithic crown and multi-layer buildup. The latter mostly consists of core material with a portion layered with porcelain powder, or a more complex multi-chromatic buildup with a thinner core material option is also available. To replicate the various optical properties emanating from the interior of natural teeth, colored porcelain buildup possessing diverse optical properties is thought to be most advantageous. However, it's highly technique sensitive and labor intensive, so there is growing dependency in coloring and staining. What we know as staining is external staining, and internal staining is done by applying powder during buildup. Now, there's an increasing trend in using pre-shaded zirconia blocks.
머티리얼 자체에 색이 올라오는 색이 내장돼 있는 경우들이 그런 블록을 머티리얼 사용하는 빈도가 늘어나고 있습니다.
We use a lot of monolithic zirconia these days. This is categorized by myself. Traditional zirconia, with a 3YTZP composition has a strength about 1000 megapascals. However, it is monochromatic, so if used without coloring, it appears as such.
우리가 사용한다면 이런 식의 쉐이드를 보이게 되고요.
Multi-layer blocks have been used more frequently in recent years, increasing the yttria content and showing strength about 700 to 800 megapascals. While these seem aesthetically pleasing, there are some concerns about strength. As of late, products that show similar shades but have a strength about 1000 megapascals have been released, which are used primarily for implant crowns. The cervical area requires more strength of about 1000 megapascal, and the incisal area requires more translucency, and these days, composite multi-layer products have been introduced and they show quite aesthetic results. I'm unsure of the exact term, but these products are being released these days. This is a monochromatic block, and this one is a 700-800 megapascal block that shows similar shade without additional coloring. Coloring is done before sintering zirconia, and staining is done after sintering, so it can be scratched off, whereas you can't with this one. This is a product with 800 megapascals. You can see that the colors are there even without coloring, but it's not really aesthetic. This is a block with 750 megapascals. From here to here, all of it has been made with this block. The characterization of these teeth are not complicated, so it's quite aesthetic. This has been fabricated using this block. When there is a significant characterization in different colors, the output can be a bit lacking. In the case of single crown, there's high aesthetic demand, so you can use a bit of porcelain. When multiple prosthesis goes in and when they need to be in symmetry, monolithic zirconia can be used to get satisfactory results. Zirconia abutment. When fabricating, you need to use a block with about 1000 megapascals, and this one was about 750 megapascals, and it shows quite aesthetic results. This is the same case. These two are zirconia abutment, monolithic zirconia crown, and this is natural tooth crown. Compared with the crown of natural tooth, the aesthetics are quite nice. This is not an implant case. This one had about 1100 megapascal strength, and here it was about 600 megapascal, and this was a tooth that has underwent endo treatment. When there's a lack of translucency in the crown, a dark shadow appears, but there's no dark shadow because translucency is quite nice. If you use the composite multi-layer block, it'll be of great help in getting aesthetic result. In general implant treatment cases, I use these blocks, and for anterior implant cases, I use these blocks. Also, you can use hybrid ceramics, reinforced glass ceramics. This is Emax type of product. There's hybrid. There's also feldspathic block, which is not frequently used for implant cases. In the case of Emax, it can be divided into Emax Press and CAD. In terms of translucency and other lab data, Emax still seems to show better results compared to zirconia. When porcelain powder is applied to Emax, it shows very aesthetic results. These two are Emax crown. They look great. Emax crown has been added on top of zirconia abutment. It's quite aesthetic. In my opinion, you can get similar results using monolithic zirconia. As for implant crown, I don't think you need to use Emax necessarily. To give you clinical recommendation, More so than the material itself, we need to have a good understanding of the case. We need to position the implant accurately, and we need to have also a thorough understanding of the design.
디자인에 대한 이해가 더 중요하다는 것을 명심을 하시고요.
For implant cases, the recommendation is to use zirconia custom abutment along with link abutment. And
모노쉐이드도 1000메가파스칼 때
monoshade 1000 megapascal zirconia block is recommended. Composite multi-layer blocks is recommended for fabricating crowns. It should have about 1000 megapascal strength in cervical area and 600 megapascal in the incisal area. Such a zirconia block can be used for single implant cases, or when aesthetic demand is very high, you can use a PFZ, which utilizes veneering powder. Thus far, I've talked about design and materials. You'll be able to get more details and do hands-on practice in offline course. Thank you.